Hello and welcome back to GP Video Podcast by Nadia. Today we are covering IBS, Irritable Bowel Syndrome, Part 3. So because I've already done IBS Part 1 and Part 2, so I wouldn't be going through everything again, but because I'm a bit OCD as well, so I'll just quickly tell you the main points. What is IBS, Irritable Bowel Syndrome? It is a functional GIT disorder, gastrointestinal tract disorder. Most common, affects around 10% of global population, and it is characterized by chronic or recurrent abdominal pain with alternating bowel habits like constipation and diarrhea. Other symptoms are bloating, gassiness, feeling severely ill. Pain is usually worse after eating and improves with defecation or with passing stool. More in young adults and females. Triggers are certain foods, stress. It's more common in females around menstruation period. Certain medications, caffeine, alcohol, anxiety, depression, sleep disturbance, and any kind of illness can trigger it. It is thought to be a diagnosis of exclusion, but these days it is also very much encouraged that you should apply a criteria. The criteria that we have at this stage, we have few others as well, but the one that I use is Rome 4 criteria. So because I believe that it is a diagnosis of exclusion. I don't know, because primary care practitioners or general practitioners can have a bit of anxiety and depression while thinking, not depression but anxiety, while thinking that what we are doing, are we missing any organic cause? Because functional bowel disorder means that there is nothing wrong with the GIT. It's just a functional disorder. It's nowadays also called as gut-brain axis disorder, which I'll talk about at some other stage. So to exclude other causes, what we can do is we can do a blood test. So blood test is full blood count for ruling out any iron deficiency anemia, because patients with IBS should not have iron deficiency anemia. I mean, yes, if iron deficiency anemia, let's say in females, is because of menstruation, which is heavy menstruation, that is another thing. But generally, they should not, because iron deficiency anemia is actually could be one of the presentations, or could be one of the symptoms of colon cancer or irritable bowel disease. So, okay, so what are the conditions that we are trying to exclude when we say diagnosis of exclusion? So that is colon cancer, polyps, irritable bowel disease, which is ulcerative colitis, and Crohn's disease. So how is irritable bowel disease different from irritable bowel syndrome? Irritable bowel disease has got structural issues with the lining and the musculature of the intestinal wall, which can be treated. So that can be very catastrophic as well. So we are trying to exclude colon cancer. We are trying to exclude irritable bowel disease, which is ulcerative colitis and Crohn's disease. We are trying to exclude colonic polyps, and in women we should also exclude ovarian cancer. So the simple tests that we can do before going for colonoscopy is full blood count for anemia. So the patients with IBS should not have anemia. CRP, ESR for inflammation. So CRP and ESR are inflammation markers. We can do that. We can also do celiac serology to exclude any adult onset celiac intolerance, including anti-TTG and anti-endomysial antibodies. So these are the tests that we can do. We can also do CA125 to just see if that is raised, because CA125 is one of the cancer markers for ovarian cancer. We do not do it usually. It's not a screening procedure as such, but it can be done if needed, to find out whether the patient has increased chances of getting ovarian cancer or has ovarian cancer. Then we can do a fecal test or a stool test for fecal calprotectin, which is one of the inflammatory markers in the feces, which will be raised if the patient has irritable bowel disease, which is ulcerative colitis or Crohn's disease, okay, or so any of these. Then we can also do a CT abdo-pelvis, which can sometimes show irritable bowel disease, cancer, and can also show diverticulitis, which can be also one of the diagnoses that we want to exclude, and can show cancer, can show polyps, can show irritable bowel disease, and the last stage is colonoscopy, which will show everything which is wrong with the gut. But as I said, that if we apply this Rome 4 criteria, we'll be pretty safe. What are the danger signs? What are the signs that a patient with irritable bowel syndrome should not have usually. One is no blood in diarrhea or no blood in stool when constipated, except if the patient has anal fissure and hemorrhoids because of the constipation. That is another thing, but there should be no frank blood or no hidden blood in diarrhea. And for that, we can do a fecal occult blood test. If the blood is positive, because sometimes we cannot see blood with our naked eyes, so we can do a fecal occult blood test, which is one of the screening procedures for colon cancer, and that will show us if there is any hidden blood in the diarrhea or constipated stool or the stool of IBS people. There should be no diarrhea at night usually. There should be no weight loss. There should be no iron deficiency anemia. Again, if weight loss is because of another reason, iron deficiency anemia is because of another reason, that is another thing. But they shouldn't be because of IBS. Pain that does not get relieved after defecation, because this pain is usually worse after eating and is usually relieved after defecation. So if the pain that does not get relieved after defecation, that should not be one of the signs of IBS. And then unexplained vomiting should not be there. Okay, I come to criteria, Rome 4 criteria as well, but I'll quickly come on to the medications for IBS. Loperamide can be used for diarrhea, and I'll come back to it and I'll explain because it's 6:30 minutes anyway. So loperamide can be used for diarrhea, which is GastroStop. Bulk forming laxatives like Isperol can be used, or other agents could be used for constipation. The only thing to avoid for constipation is lactulose syrup because it can cause more bloating. Otherwise, everything else can be used for constipation. Then antispasmodics for cramps like Buscopan. So the symptomatic relief can be obtained through loperamide or GastroStop for diarrhea. Constipation agents for relieving constipation, especially bulk forming laxatives. Antispasmodics like Buscopan. Then what is the other treatment? Low dose tricyclic antidepressants like amitriptyline. That is one of the treatments for regular. The other ones that I said are taken as needed. While this one, if we institute it for IBS, we're talking about IBS, then it should be regular. Let's say 10 milligram of amitriptyline every night should be used. Okay. If that is not helpful, let's say we tried it for 6 to 8 weeks, but it's not 6 weeks to, let's say, 3 months, but it's still not helpful, then we can try SSRI antidepressants like fluoxetine and all. According to the new investigations, liraglutide, which is Saxenda injection, if you remember, this is one of the weight loss injections that is good for IBS, or Mounjaro, tirzepatide, again a weight loss injection that is also good for managing the symptoms of IBS. The other one is called mebeverine. It is also an oral medication which can be used 3 times a day with food. So any of these, it could be the antidepressants, either it could be low dose TCA or it could be SSRI antidepressant, but they can be combined with liraglutide or Mounjaro, or they can also be combined with mebeverine. I'll come back to all of this in my next podcast.